So good morning, everyone. Happy to see so many familiar faces and friends in the audience for Blooming Day, Ohio. For those that don't know me, my name is Celina Cunanan. I'm the Chief Health Impact Officer at University Hospitals. I'm also a certified nurse midwife, so I've been serving the Cleveland community for the last 25 years of my career. So really privileged to moderate this discussion today in a topic that's so near and dear to all of our hearts here on this panel. So before I get into the meat of the discussion, I'd love to hear from our panelists to talk to a little bit about who you are, what you do, and what your organization does. So Angela, I'll start with you.
Good morning. It's still morning. Angela Newman-White. I have the honor and privilege of serving as the Executive Director of First Year Cleveland. First Year Cleveland is a public-private partnership, a backbone organization, working with community to identify community-driven solutions to ensure that every baby celebrates their first birthday. Originally, we were founded in 2015 as Commissioner Mills talked about earlier in response to the high Black infant mortality rate.
Oh, no worries.
We are still heavily focused on making sure that Black women and communities are thriving. But the ultimate goal is every baby celebrates their first birthday. Just a little bit about myself. I mentioned, I spent 20 years in public health, leading a lot of the maternal and child health work. Got my start with the Moms First program through the Cleveland Department of Public Health, and then moving on to the county. And so, understanding that prevention is the way to go. We must move through this work with a prevention lens. I'm honored to be serving in this capacity with First Year Cleveland.
Thank you. Tonae?
My name is Tonae Bolton, and I serve as the Senior Director for Strategy Engagement. Think so. At Birth and Beautiful Communities. I started with the organization as a doula and transitioned over to the administrative side a few years ago. Our organization provides free doula care to women, specifically women of color. And we also provide free postpartum care for our clients as well. And just like Angela said, it's very important that we ensure that babies reach their first birthdays. So we've been in existence. This is our 11th year. We will also be opening a birth center next year so that clients that have low risk births can come in a safe space, in a safe place, in a tranquil space to be able to deliver their babies. But we follow our clients until babies reach their 1 year birthday. And then, people think about it as a 1 year, but you're really developing a relationship with your clients. So I have clients whose babies are 3 and they still call for support. They still call to say, hey, Ma. So I have an interesting story, but I'll save that story. But the relationship building is really key in terms of reducing infant mortality, reducing stress. So that's our organization. And we really focus on those intimate relationships with our clients.
Such incredible work that both of the organizations do. And I've been privileged to help being a part of both of their organizations and work in collaboration, because I think what we've learned, right, is that this is not a one system issue. Mm-hmm. It is multi-system. It is so complex. And we're never going to move the needle unless we all work together in this space. So I think we have Mark on the line, and I'm not sure if we'll be able to see him on up above us, but Mark, if you're able to, if you could give us a little bit about who you are and what you do, and what does NashvilleHealth do?
Yes, I appreciate that. And am I coming in loud and clear?
Yes, you are.
Okay, good deal. Well, thank you all for having me here. Mark Yancy, CEO of NashvilleHealth. I am I think the lone non-local. It's not necessarily in Ohio on the panel, but I've known Vicki from her time being part of the NashvilleHealth board, and appreciate the invitation. But the organization I lead was founded by Senator Bill Frist in 2016, based on the fact that Nashville is often looked at as the healthcare capital of the United States, if not the world, from a GDP standpoint. I know many people view us as a music city, and it's the preeminent title that we wear. but we really are a healthcare behemoth in terms of having so many companies that are either here or headquartered here. HCA, Vanderbilt, LifePoint, Ardent, I can go on and on. Same thing for managed care and insurance services. The issue, though, is that when you look at our health profile as a city as compared to the cities that would be our sister cities, or even the cities that you would say we compete with for expansions and relocations, i.e., people, we are far sicker than everyone else. Those are cities like Austin, Denver, Atlanta, Charlotte, Raleigh, Durham, Dallas, Fort Worth. But those cities do not call themselves or do not wear the moniker of the healthcare capital. And because of that, what it suggests is that we're just not aiming at the right target at wellness. Many of you that are, very familiar with hospital care, quality is really about doing the same thing the same way every time and not harming patients. You could be green on that, and it has woeful little to do with your patient's everyday lived experience with how chronic illness turns into an acute presentation. I say it in that way to say that we exist to aim our talent and kind of serve like an air traffic controller or a conductor. I'm saying, how do we actually aim at a different target, which is engaging those non-medical determinants in our communities that actually really do predict and prescribe how healthy people are. So we lead partnerships where we will basically say we'll bring a clinical entity with non-clinical entities, and we'll create demonstrations that basically say if people have access to better transit, better food nutrition, better mobility, maybe it's a fitness pass. If we coordinate all of those things and people get healthier, we then work with the city to say, how do we introduce a sustainable asset in this area so that people can get healthier? That's probably the quickest way I can explain what we do. But hypertension, maternal health, things of that nature are squarely in the things that we do, which is why we've been invited here today.
Thanks so much, Mark. And I think we'll get into that a little bit later around, kind of what not only what's happening here in Cleveland, but what is happening across the country, because this is not just a Cleveland problem. We know it's a community, it's a problem. And when we talk about maternal mortality, infant mortality, that affects all women across this country, mostly Black women. And so let's talk about that, about what's being done in other cities, and so to learn from certain organizations or other entities about what we can do here to bring some solutions here to Cleveland. So, but let's get into here in Cleveland. So I'm going to direct this question to both Angela and Tonae. Cleveland continues to have one of the highest infant mortality rates in the nation, despite strong healthcare institutions. And I know that both of you have heard me talk about this. I just talked about this last week at the City Club. Infant mortality is a systems issue. If we think it's a healthcare issue alone, we are going to fail each and every time. So we need to talk about across industries and region what everyone is doing to promote the health and wellness of women and children, the most vulnerable people in the community. So tell me a little bit, we've heard the stories. I've heard your stories, Angela, about things that you've done for First Year Cleveland in terms of community engagement, what you've heard in your listening sessions. And then of course, Tonae, in terms of, the incredible work that BBC does in the community and really engaging to provide support services to women in the community. Can you each share a story from your work that illustrates why this disparity in this crisis persists and what gives you hope for change?
Well, I think, and exactly what you said, that healthcare is not the solution. I think, when we even mentioned the statistics that Commissioner Mills talked about, that Cleveland is, one of the poorest cities in the nation, and poverty is a huge contributing factor to the overall health and well-being of our community, specifically maternal and child health. I think we do a great job of creating solutions and looking at evidence-based interventions and bringing them to Cleveland. That is illustrated by all of the great work that's being done, not only at the grassroots level, but systematically. And I think one of the missing pieces that continues to kind of hold us heavy here in our community is the understanding of the full comprehensive approach to infant mortality. One example that I'll provide is maybe way back when in 2015, when we did expand centering pregnancy throughout the entire county. UH was one of the first, the champions to bring the centering pregnancy model to Cleveland. It's a group prenatal care model that not only provides consistent prenatal care, but it offers the opportunities to build relationships amongst the patients in the room. And so addressing that need that we all have to build community, to have that necessary network of support. But when we think about all of the barriers to actually get to or participate in this centering pregnancy model, despite having it in every single health system and every single federally qualified health center, the uptake wasn't that great. The assumption was this is the solution, because it is. The outcomes are phenomenal for women that can take advantage of it. And so our job at First Year Cleveland is really thinking about how do we create this ecosystem to where, yes, centering is available for every woman that can get there. And a doula is available for every woman that would like to have a doula, and a community health worker, and all these other amazing and impactful services. It's our responsibility to think about the women that are not being engaged and how do we meet their needs from an upstream perspective, and ensuring that they have their basic needs met to ultimately have less stress and a healthier baby.
And so for me, at dinner last night, we had an interesting conversation around education. I am a former adjunct professor at Case Western Reserve University, and I used to teach a class called Theories of Oppression and Social Justice. And in that particular class, I really helped people to understand the power dynamics and to understand oppression and the systems that are in place to keep oppression alive and well. And I really think that education is really a big proponent. We advocate at Birth and Beautiful Communities. We educate our doulas differently. We educate them with a cultural lens, historical trauma, medical distrust or mistrust. So we really educate them around some of those systemic things that happen to cause delay of care, and to be able to impact and be with the clients that we serve, the birthing persons that we serve. But I really think that if we, and that just goes to my background of diversity, equity, and inclusion, but I really think that if we educate providers and educate people and make it a continuing education, like at Case, you had to come and see me before you got your degree. So I was one of those last classes. At Cleveland State, I was one of those last classes. But in terms of medical education, there's not a me in those type of rooms. And so you perpetuate systems, cycles, stereotypes, bias, those things that you don't even know that exist because of your upbringing.
Tonae, you're speaking my love language right now.
Yeah. So I really think that, having those educations, so I'm creating a provider education now with this new NICU project that I'm creating, because toxic stress is really, really a real thing. And in order to impact these different systems, you have to have some type of meaningful impact. If I talk to you about systemic racism and you've never experienced it, you have to be open enough to believe somebody who has experienced it in order for change to really happen. So I think those type of things and provider education, continuing education would really help to impact the systems, because we have some of the greatest healthcare here. But I've been in rooms where some of the ideology or the mannerisms, the micro inequities that exist, the subtle things that make you feel like you don't belong, you're not listened to. If this is your 5th pregnancy and you're having pain, for someone to say, oh, this is your 5th time around, this is, you're not new to this,
Right.
but I'm being ignored. And then this is an issue that can potentially cause me my life.
Yeah. Right.
So I think
even the way we frame those things, like as a provider, like somebody's coming in their 5th pregnancy and they're saying, I'm feeling pain. Let me ask you more questions about it. Tell me what it feels like. These are the things I want you to look for. Okay, this doesn't sound like it's anything yet, but here are the things I want you to look for.
Absolutely.
And I want you to call and I want you to come in. Right. And I want you to, if there's anything you're worried about, I want you to make sure that you feel okay with this, and making sure that we not belittle people's concerns, I think is so important in that space. But when you're talking about training, I mean, this is a lot of what, this is one arm of my office, and we talk about provider training. And really how we frame it is really, how can we make sure that all of our providers are given the tools to be service a multitude of different communities in the best way possible, that they're being their best selves at work, and to be able to provide the best care for every single person that walks in the door. It's a big lift.
Yeah,
It is a big
because
lift.
even though you have the tools, you have to really
Yeah.
use those tools and be empathetic and genuine
Yep.
when using those tools.
Absolutely, absolutely. So when we talk about, the root causes of issues like maternal mortality and infant mortality, we know access to care is only part of the equation. Issues like poverty, housing instability, and systemic racism play a major role. I know from our perspective as a healthcare organization, we have the Community Health Investment Strategy, where we invest in things like our Food for Life program, housing. We've just made an announcement of a $3 million investment in housing project in Huff. We already have one at the Davis apartment homes. We have a community, a wellness center there. Community health workers, the way that we put our Ahuja Center for Women and Children in the Huff community, which had the highest infant mortality rate. Our programs for opportunities, upward economic mobility, our earn and learn programs, our step up 2H, even the things that I do in youth career, those are all important parts of it that, we're doing. I think we try and do what we can, but these are, like we said, systems issue. How are your organizations addressing these deeper structural drivers of poor maternal and infant outcomes? I'll start with you, Tonae.
For our organization, one of the things for us is advocacy. So the way in which we train our doulas to go into the organizations and just the questions that the provider should ask, we train our doulas to be able to ask those questions. We also help to empower our clients' voices, because many times you feel like you don't matter, like you don't have a voice. And so with our organization, we really we do education for our prenatal. If you're pregnant or if you postpartum, we have our mental health services. We have our director of behavioral health here in the room. We look at our clients and we do a whole wraparound. So we've looked at the social determinants of health. If there is an issue with transportation, we provide Ubers. We provide Ubers to the grocery stores because we know that there are food deserts. So we make sure that you can get to the grocery store. We make sure that you can get to your appointments. We make sure that our teen program, we have a teen program, and we don't just let you go after your baby turns a year old. If you're a teen parent, we follow you until you're 27.
That's amazing.
We also have in our organization, we have Birthing Moms Unchained. And in Cuyahoga County, before we became involved, if you were pregnant and in the women's, if you were in the women's prison, the one that's here in Cleveland, when you delivered at Metro, you were chained to a bed and a guard was in your room. So we make sure that moms are no longer chained and they can give birth in a humane and dignified setting. Yes, thank you. The guard stands outside because this is still your birth story. I don't care what your circumstances are. This is still your birth story, and you can birth and labor and in your own way. So we are into systems. We partner with all of the healthcare organizations. We are doing things to really impact the system, to really impact change in our community and make sure that our birthing persons are able to eventually advocate for themselves, that they feel like they're powerful, they feel empowered in their voice. And we educate them on what to expect. We educate them on signs and symptoms. We have classes every week for our pregnant women and our postpartum moms.
Right.
So we do a lot.
Amazing,
with that.
amazing work. Mark, from a Nashville perspective, what are some of the things that your organization is doing to address deeper structural drivers of poor outcomes for moms and babies?
Yeah, it's a great question. And one of the things that I think in trying to think outside the box on it is kind of addressing the narrative of it. I think a lot of us in the room are probably deeply passionate about the work because it's either work that we've been doing or work that we have a personal passion for. but a lot of the things that represent these structural issues and structural inequities and lack of assets in our environments are not necessarily influenced by our decision making or our ability to provide capital to those particular things. So you want to be able to express some of these challenges in a way that people that don't have the orientation to the problem that we have can understand. Meaning, it's not often understood from a housing standpoint that one of the chief ways of making sure that a pregnancy is safe and that infant mortality numbers are down and maternal health outcomes are better is stable housing, over the course of the pregnancy. But the issue with that is that healthcare structures generally do not control or influence those are not the decision makers as it relates to that. I'm saying that to say that a lot of the times what we try to do is knowing that housing, knowing that food and nutrition, knowing that transit, knowing that all of these things play a central role in a mother's ability to have a healthy pregnancy and deliver a healthy baby and then have a healthy child. It becomes yeah, talking about the lost productivity, the lost ability to work, the things that actually impact our community in a greater ways. I think sometimes when we view some of these things that we're talking about, it's almost as if we're saying that mothers and pregnant mothers and families need the help. And that's true, but what's also happening is when we have these terrible outcomes or we have postpartum issues that keep a mother from going back to work, what's really happening is their time and talent is not available to everybody else. Their access and their resources not available to their job. And as much as that sounds like kind of converting it into another realization, it really is saying we have to realize that this is not charity and help. This is we are leaving our greatest effort and our greatest economy, like the things that drive our economy, we're leaving them on the table. We could be much better than what we already are. So as much as it is a deficit in saying that mothers don't have access to these certain things or mothers don't have access to doulas, we try to say if they did have access to this, there's a way for that mother to have a healthier pregnancy, a healthier first 3 to 6 months in that child's life, which will ultimately allow that mother to get back to work, will allow that child to work to become a productive and thriving child. And in one way, I'll situate it just in a way of saying it is like if we're saying that our life expectancy, for example, in Nashville is 2 years less than that of in Austin, which is true. Sometimes you have to convert that understanding to say that, well, that 2 year variance is chronic illness. And that chronic illness variance is ends up in people's claims in terms of how they pay for their workforce. And those are things that companies really do study now in terms of where they would like to put a workforce, particularly one that has to show up in work. That's not exactly the same example as what we're talking about, but what we try and do is make it relevant to decision makers that ordinarily would not necessarily have a reason to understand this in the way that they need to, in a way to say that we are actually uplifting our city beyond just saying that we're working on maternal health and child outcomes.
That's great. Angela, let's talk a little bit. I know, Mark, you just mentioned about it, a little bit about advocacy, and I'd like to talk about a little bit about policy. And Angela, you've often talk about, I hear you talk so much around a both and approach in meeting immediate services, meeting immediate needs while pushing for upstream policy change. What does that balance look like in practice, and how can Ohio scale this dual strategy statewide?
Absolutely. Yes, it's a both and. I lead with this whole, it's not a theory, but this perspective transformation, shifting our thinking from individual responsibility to systems accountability when it comes to maternal and infant health. And I think it is our responsibility from a systems perspective to make sure that there are consistent investments in direct services to meet the needs of families. Because the reality is people are in crisis right now. And so I do understand that it's very expensive to provide the direct service on the intervention side, but from my public health lens on the prevention side, thinking about the policy changes that can complement the direct service model. The one example is the Healthy Beginnings at Home project at First Year Cleveland was grateful to have introduced to our community. We're providing free housing to pregnant women for 24 months. Yes, I know that it's not sustainable, right? We cannot provide free housing, but the whole purpose behind this is to collect the data to justify, because we know that housing provides a protective factor for infant and maternal health. Can Ohio come to a place to where we are for pregnancy as a priority population for subsidy? Our state adheres to the HUD guidelines that prioritize the aging population, folks with disabilities, and veterans. However, if we could guarantee housing for families, at least through their pregnancy, through the first year, what does that mean for the future, of our community? Another both and approach in thinking about the policy side is around diaper access. When you think about having some diapers, no, that's not going to solve an infant mortality, however, you think about the stress on a family that has to choose between purchasing diapers and getting food or paying their rent. There is no current subsidy for diapers. If you have income restrictions, some families are forced to have their child be soiled for a longer period of time. There's limitations on accessing childcare. We do have the Greater Cleveland Diaper Bank here in the community, and it's doing great work, but we have supported the Diaper Bank at First Year Cleveland. We're also on the advocacy side trying to pursue a Medicaid waiver. There are two other states, I think it's Iowa and Tennessee, that now they have a Medicaid waiver for diapers where families get free diapers up until the child turns age 2. Why can't we bring that to Ohio? So that's what I think about. Like right now, yes, diaper banks can provide free diapers, but can we, for sustainability's purpose, find ways that where there's a policy that can complement it, that's going to, alleviate some of the burden, and then we can spend less resources because folks already have it.
Yeah, I just want to say too, in terms of diapers, right? The incredible work that the Diaper Bank does. I want to put a plug in for our Hoosier Rainbow Center for Women and Children. Their pharmacy provides a pack of diapers for $2 and wipes as well for $1. So if that's a resource that's needed in your community or clients that please let them know. Come and visit us down over at 5019 Euclid, because we're there to help service everyone in the community, not just our patients that are there. Anyone can come in. So Mark, can you tell us a little bit about policy and things that you're doing in Nashville?
Yes, I think it's a great discussion around, we're dealing with kind of the outcomes of people not having, exposure and assets in their own communities to what they need to thrive, be it housing, be it food and nutrition. And so, for us, it becomes things like, and I really appreciate the comment around the diaper waiver that we do have in Tennessee, and that's an example of advocacy success turning into some policy. But one of the things that we try and do, for example, if we have a demonstration, and we have one for maternal health that we're developing now that follows a hypertension model that we have. And it came from this basic realization that in this same area of Nashville, it's called North Nashville. It is a food desert and a food swamp, meaning you can't get good fresh fruits and vegetables. At the same time, there's a proliferation of very inexpensive, high sodium, high processed foods that you can get relatively easily. That is going to predispose you to chronic illness, predispose you to certain outcomes. And so the question that we ask so we can get to the advocacy and policy portion of it is, well, if there's a care center there in that neighborhood and they give that patient a care plan, be it around maternal health, be it around hypertension, what is that patient going to struggle with when they leave the center in implementing from their care plan? Meaning, if they're going to tell you to eat better, to follow a certain diet, how are you going to do that in the same area that predispose you to having a chronic illness? How can you have a therapeutic response when your care plan may say, move more, exercise more, eat better, but you can't do it in that environment? So if we know that to be true, what we'll do is we'll take a demonstration where we say, well, is there a nonprofit or community-based organization that can make culturally competent fresh food, vegetable meals and actually have them on site to be delivered to the care center? The answer to that is yes. Now, that does not make up for the fact that there's not a grocery store there, but it does provide some mitigating factors. If in so offering that, people get healthier, let's just say from hypertension at the same point, you now have data that says some of what you're experiencing is a lack of assets or a structural asset that's in that community. But at that same time, because we're looking for, a way to scale that demonstration for it to be sustainable, you need to have the attention of the Chamber of Commerce. You need to have the attention of the health department. You need to have the attention of the mayor or the metro government office to say, if this proves to be true, we then need for you to actually put a sustainable asset here that makes up for the demonstration going away at the time that it does. I say that to say you try to tack together structures that would not ordinarily be coordinated, meaning a food and nutrition, a transit nonprofit, a community health center. But if you're not aligning that to some sort of municipal or government or advocacy approach that can actually sustain it, I like what I heard earlier. It's great, but it may exist for a year or two, but then what happens after that? So the importance and the imperative of having those audiences on the front end and having those structures built in on the front end, so that we don't make the mistake of believing that when we do some of these efforts, they are the fix. A lot of the times these things that we're doing are the path finding that someone else needs to scale, that the city needs to scale. So saying all that to say that when you do these efforts, it becomes very, very important to have your health department engaged in it so that you can have the conversation with the city. Then if you can have a conversation with the city that may have federal funding or state funding, you can have a conversation with the state. So it's important to look at it that way so that your demonstrations are not just these peaks and then followed by these valleys.
That's great. Um, Tonae, we've seen powerful results when community-based models like doula programs, culturally tailored maternal care integrated into healthcare systems. We at UH have been really proud to have been the first healthcare partner you guys, Birthing Beautiful Communities, had when you had that initial grant to start it. And we started it in our Centering Pregnancy program, which was highly effective. What have been some of your most effective collaborations? And more importantly, how can managed care organizations help expand these efforts?
We have so many collaborations, but I think one of the most important collaborations that we have is Cleveland State University. So we have a researcher, Dr. Heather Rice, that works with us, and she is amazing in making sure that our work is put on paper, it's published, we have data-driven results. So that is one of our biggest collaborations, and it allows us to go and speak on a national scale at conferences and things like that. So there is a direct line with research and how what we're doing is improving lives and saving lives. The hospital systems, I think, are great collaborations. We're in all three of the hospital systems, and and they trust us. So if we have a client who comes in without support, who doesn't have anybody to support them during labor and delivery, the hospital will pick up the phone and call us to say, hey, we have a patient here who doesn't have support. Can you send a doula? So we have those collaborations. We have First Year Cleveland. We have collaborations with mental health providers where we provide, we partner and we provide Black health mental health therapists and providers to make sure that we are addressing mental health needs of our clients. We recently have Infant Massage USA, so we now have some of our doulas who are now certified infant massage therapists, where we go out and we teach families how to massage their babies that are less than a year old. We're also working with Now Womankind, who provides free maternal health services for up to 28 weeks. And we do work with managed care providers as well. And I think that, thinking outside of the box as to how managed care providers can really help us, especially in funding. Like everything that we do, we provide free to our clients.
Yeah.
So we don't charge for anything. So we need help in order to continue these services in the community.
So just put a plug in for, and I think your organization has done such an amazing job with your leadership team, obviously under the direction of Jasmine Long, our CEO.
Absolutely.
Who has created such strong partnerships across the region.
Yes, she has.
That's the way it should go, right? We're all in this together.
Yes.
Want to put a plug in for people who need to, you just said you offer these services for free. If there's anyone in healthcare organizations or beyond in other agencies, great opportunity to support the work that they do. So if your organization or other industries or partners or businesses that you know of, please support the work that they do, because they provide such a vital service to patients that we can't provide necessarily as healthcare organizations, but our patients desperately need. So we got started a little bit late, so I'm going to reclaim my time like Maxine Waters and talk a little bit about, because Nima said I had 45 minutes. So I want to talk a little bit, because Blooming has helped us sponsor this. Let's talk a little bit about technology and equity, because we know that a lot of the things that we do in our organizations are very people intensive. We can't get to the scale that we need to sometimes, right? And how can we meet the needs of all people and in different manners? Some people don't want direct contact. Some people would like technology applications, So technology has the potential to connect mothers and families to resources in real time. Angela, you've talked a little bit about, technology and its usage. Are you using anything in First Year Cleveland? Or if you're not using technology to help connect, how can technology fill that gap?
Well, right now we've been working tirelessly on launching our mobile app, resource finder app called First Year Connects. So it's web-based. It's web-based right now. I'm just waiting on approval from Google, because apparently there's a 60-day waiting period. But this is a digital platform. It'll be on both the iPhone and the Android, where it's based on location. You can search a service based off what you need. The interesting part about this app is that it's populated by our community serving organizations. And so what's great is that it allows for everyone to be involved. So you have the opportunity to just go to our website and upload your information, but it auto generates a communication to the provider every 3 months. So you have to confirm that your information is still up to date. And so we don't run into the issue to where someone seeks the service and it's no longer available. But we're hoping that this will not only shift the power to the consumer on identifying a resource to meet a need, but also support our direct service organizations who are also maybe looking for resources for their the patients and clients that they're serving.
Mark, is there anything you're using in Nashville that we can learn from as far as technology for equity solutions for communities?
Yeah, I think that you all probably have better answers from that, being that you are dealing directly with the individuals. And for us, we're more of a B2B, a business-to-business operation. But having said that, I think the things that are around a mobile app and things that allow a user from a cell phone to coordinate things. I give a really good example of an existing technology that maybe can be integrated into some of the technology that was already quoted. When we started having meals available at Matthew Walker Comprehensive Health Center, which is a health center that we're working with in North Nashville, the patients would pick up a meal as they came in for their appointment, but they may have maybe 2 appointments a month. They pick up maybe 2 weeks worth of meals, but there's a gap in that if they don't come to the clinic, they would not be able to pick up the food. And so if you're trying to, assess how does having access to culturally appropriate but low sodium and better prepared meals will actually lead to a better outcome, you don't want necessarily the gap that may occur from them not coming to the clinic. So one of the things that we were able to do is to get DoorDash integrated with with having those patients being able to, from their own home, basically say that I haven't been in the clinic in this amount of time, or I know this will be my gap. I can actually have this meal delivered directly to my home. And then the other piece to that too is, if we've had a fitness center that is in the same neighborhood, but not necessarily in walking distance for a lot of those patients. And so one of the things that we've worked on is having a Lyft partner with one of our local transit agencies, Senior Ride, to say, how do we actually use the technology that you would use as ride share to be able to get them directly to then having both the discretion and like the dignity of being able to go to the fitness center when you want to be able to do it. So I would say that while those are not what I would say are new technologies, anything that, as was just described, that centers like the mobile process of having those referrals and resources in the patient's hand, allow you to have these demonstrations that don't have these gaps in them because you don't have a technology way of addressing the fact that the patient is not right there in front of you. So I would say that mobile apps and things that are that do that allow our individuals to connect to existing technology in the vein of a care program. And I think those types of things are helpful going forward. The more you can do those mobile apps, the more you have options to do things like that to connect to existing technology.
Thank you. So speed round, 60 seconds or less, 30 seconds or less, and then we'll open up to questions. Tonae, we began this discussion talking about systems problems, right? Maternal and infant mortality is a systems problem, and it's everyone's work.
Absolutely.
Everyone's work, not just us on stage, right? It's everyone's work. How can we invite other people into the space? What is one action that you think is necessary for other places that are not direct service providers for women and children? What is one thing that they can do in this space?
I think we have to get into these rooms more often.
Yeah.
And we really have to go back to that community-centered model and sharing resources, sharing best practices, sharing the things that we need to do for one another. I think that that's going to be key in some sustainable change and creating impact. So call us, invite us out, talk to us. We had an organization that called, invited us out, and now we're collaborating to do some things together. So
it's
I think
wonderful
that those are the things that we probably need to.
Mark, from your perspective, what's one thing that our organizations, other businesses outside of direct service providers can do?
I think to the point that was already made is raise the narrative, raise the profile of the narrative. I was, to say this quickly, we need to talk in terms of if we can't take care of women and children, we can't take care of anybody. And you almost have to turn it into that so that folks understand the magnitude of it. And if we can't take care of women and children, we surely cannot take care of a family. So just putting it more broader terms so they don't pigeonhole it as a niche issue. This is an issue that affects everybody because it affects women and children.
Angela.
Yeah, that was well said. It's
Yes.
really about, like, from the business perspective, what can you do for your own internal policies that support families? How do you make it easier for people to come to work and sustain their lives, whether it's paid leave, which is a huge issue in our country. Families don't have access to paid leave, and that's many are returning back to work in 2 weeks. The other piece is around civic engagement. I know this was mentioned earlier as well. Voting matters. And so supporting employees around voting, educating their community partners and families around different interests of candidates and issues, and getting people to the polls. Are there opportunities for you to get folks to the polls? I know we only supposed to have one, but the last one is also invest. There's organizations and businesses that do have some community investment or benefit dollars. Organizations like Birthing Beautiful Communities or local, efforts. Put your money where your mouth is, because folks need funds to continue to do the work and support our families.
I'd like to open it up for some questions if we have a couple of minutes.
We do, and I can call on you. Anything on the chat? As we're waiting, one organization I didn't hear a shout out to that I want to take an opportunity. I chair Go Red for Women for the Heart Association.
What is it called?
It's called Go Red.
Go Red.
Heart
American
disease.
Heart Association.
Heart disease is the #1 killer of women. And what I'd like to say is one of our awardees this year actually was a firewoman who does CPR training for families who have babies. There are a number of babies who actually die because parents are terrified to do CPR. And so if you're not working with the Heart Association, they have an awesome program. I would sincerely invite you to bring them to your table because they're doing a lot around infants and children, particularly young mothers who have had strokes when they're pregnant. So
I think University Hospitals that's our, key partner. Harrington Heart and Vascular Institute helps to, promote Go Red for Women every year. It's a fantastic event in terms of long-term care for women. We haven't even gotten into the menopause space or any of that. Maybe it's the next discussion. I don't know, but certainly important.
Back there,
yeah.
So maybe
I'm with you, honey.
Questions? We can call on you. This is such an awesome chair. She'll call on you.
Yeah. Questions in the back.
Right here. Good. Thank you.
Good morning. I really enjoyed the comments. My name is Cindy Davis, and I'm the owner of Seven Streams Consulting. We work with organizations like all of yours and even entrepreneurs to help them close up some of these gaps. Right now, I'm working with a project called All Our Babies Cleveland, and I know you know about it because you're one of our partners from Birthing Beautiful Communities. So one of my questions to you, but also to the other people that have presented today. We've talked about many of the social indicators of health, but one that I think gets missed often or glossed over is the role of faith in families healing and access to care, and even at the levels of the corporate level. We don't discuss it at all. So I just wondered if you had any commentary about that, what you're doing, or whether you agree with that.
Yeah, I mean, I would just say from a healthcare perspective, right? We have an incredible chaplains within our organization that provide culturally responsive care to any faith. And it's one of the things that I think we need to, thank you for bringing that, because that is part of the rich diversity of people and how, and what I consider a culturally responsive care model, right? How are we delivering care in a culturally responsive way? Whether that's by their faith, by their gender, by their ethnic culture, whatever that might be, we have to meet people where they are. So faith is a huge part of that. I think partnerships with faith-based organizations are incredibly important in the space. And we've had numerous throughout the years, our strongest being the one with Olivet Baptist Church, in which we provide, they own the land. We built a healthcare center, and we have, connections with the Community Development Corp there, and we try and do programming at Otis Moss in conjunction with Olivet Baptist Church. But I'll leave it to Angela and Tonae to also speak about that.
And we also have strong relationships with our faith-based partners, not only through providing education and information, through, events being held to make sure that everyone knows that we do have a problem with infant mortality, but then also providing resources to that churches so they can not only with their congregation educate folks and provide information around breastfeeding and some of the protective factors, and then to share the resources. Way back when this was back in 2016 with our one community effort in 44128, the coolest partnership with the faith-based partners was around breastfeeding, where we provided mini grant or stipends, $500 to establish or enhance breastfeeding friendly spaces to increase breastfeeding rates amongst Black women. And, I asked one of the pastors, which I always say this because it still is funny to me. I'm like, why don't you allow women to breastfeed in church? And he said, because there is no eating or drinking in a sanctuary, but the fact is, it's like, if you feel supported to breastfeed at church, you're more likely to do it longer, at home. And so we were able to provide 8 churches with $500, and they created spaces to where you can during church, breastfeed your baby.
They definitely would have liked me
Nobody
in that
can make
space,
up
because
these
that's where I
stories.
was. Yeah,
What do you say to that? I'm like,
Right. Okay.
I know.
Mark, did you answer? Or I should do a big shout out to my friend Mark. I've worked with Mark for 15 years? Ever since he took over NashvilleHealth, he's an awesome resource.
I can't hear you in the back.
Oh, you can't hear? Oh, sorry about that. I just wanted to give a little shout out to Mark because he's an awesome partner in Nashville, and I've been on the board with NashvilleHealth. They've done incredible work, and he promised for our next meeting he would come here personally.
Well, thank you, Vicki. I appreciate that. And I appreciate being invited too.
Tonae, do you want to talk a little bit about faith in some of the things that you do? I know, like even with Pale Connect, which is our infant mortality, I'm sure that faith becomes a large part of the work that you do in Pale.
Yes, so we have Tammy Jones in the room, and she runs the behavioral health program, and she runs that PALE program as well. And so we're in partnership with PALE, and she makes sure that our clients have the services that they need in terms of any type of infant loss, connecting with any type of faith-based organization. But we also understand that not everyone is Christian. Yeah. So for our organization, we have Muslim doulas, We have Christian doulas. We have doulas who are just more spiritual than anything. So we make sure that we respect when we create a birth plan with our clients. We make sure that we ask those questions so that we can be respectful of their faith. We can be respectful of their wishes. If there are anything's culturally that need to be addressed at birth or done at birth, such as some faith-based have enemas at birth. So we make sure that we go through all of those questions and make sure that we're very respectful and that their birth plan, because that's part of the birth plan, that's part of birthing a baby, because you're really connected to your faith. So we really make sure that we stay connected with them as
Taking
well.
care of the whole person.
Just so
Absolutely.
folks know, this isn't the end of the conversation. You're seeing where you can probably smell the food wafting into the room. So we want to continue the dialogue, particularly with maternal and infant care in that discussion group.